Hello, my name is Hee-jung Kim. I'm breast surgeon in Assam Medical Center. Hey Matteo, can you introduce by yourself?
Hello, ciao everybody. My name is Matteo Lambertini. I'm a medical oncologist from the San Martino Hospital in Genova, Italy, and adjunct professor in medical oncology at the University of Genova. It's very nice to be kind of virtually back in Korea and to GBCC.
How have you been?
Good. It has been a challenging year, as for everybody, also with these online conferences and all the work related to COVID-19. The situation in Italy has been quite bad for a while. Now we are trying to get better, slowly better. But yeah, it has been a challenging year. But right now I'm good. Thanks.
So Matteo, I will ask something for young women breast cancer. And what is the characteristics of breast cancer in young women?
Yeah, young women with breast cancer are a kind of special patient population among breast cancer patients. Breast cancer is actually the most common tumor type among young women. And if we say all over the world, there are around 30% of cases of cancer diagnosed in people under the age of 40. So 1 out of 3 new cancer diagnoses in women under the age of 40 is indeed a breast cancer. And there are special age-related issues that should be considered in the care and in the management of this patient. Among them, treatment-related issues. One of the clear example is the use of adjuvant endocrine therapy, which is completely different as compared to postmenopausal women, with different issues to be considered in the choice of this treatment. Other important issues, for example, genetic testing. Young age is one of the criteria to refer women to genetic counselor and to be tested at least for the BRCA genes. And then there are other important age-related issues. Among them, fertility and pregnancy concern are highly relevant, and I think we are going to discuss about them in this talk.
So what is most different thing regarding like postmenopausal women?
So the most important difference is, as I've mentioned, some age-related issues, among them fertility and pregnancy, are highly relevant. But also in terms of treatment, there are differences. And I've just briefly mentioned the use of adjuvant endocrine therapy. We all know that in postmenopausal women, we can use tamoxifen or an AI, a sequence of these two treatments. For young women, is actually much more complicated because there we have tamoxifen alone, but we have also the combination of ovarian function suppression plus tamoxifen and plus an aromatase inhibitor. And when we use the combination of OFS plus an aromatase inhibitor, we have to make sure that actually the patient is really kind of postmenopausal, so that she's really that her ovarian function is really suppressed. And the choice of the best adjuvant endocrine treatment is quite complex, and I would say more complex in premenopausal young women as compared to postmenopausal patients. But probably the most striking difference is the fertility and pregnancy related issues, which is something, of course, that is specific for young women.
So beyond the breast cancer treatment, young women with breast cancer have many other issues regarding pregnancy and fertilities. So how do you consult for fertility preservation for that woman?
Oncofertility counseling, so the discussion around the risk of developing treatment-related infertility, the possibility to have a pregnancy following treatment completion. So this counseling is nowadays considered mandatory as per guidelines, including the recently published ESMO guidelines on fertility and post-treatment pregnancies. So actually, whenever we see a young woman with breast cancer at the time of the first medical consultation, when we discuss treatment with this patient, we also have to discuss the potential negative consequences of this treatment on her ovarian function and fertility. And patient interest in fertility preservation, meaning patients that are interested to have a pregnancy following treatment completion, they have to be referred to fertility units where they can receive a more in-depth counseling on the different available strategies for fertility preservation. Among them, standard options are embryo and oocyte cryopreservation. These are the two first options that should be discussed with all women interested in having a pregnancy following treatment completion. Actually, women under the age of 40, because for older women, the success of this procedure is quite low.
I think your meta-analysis study is very helpful for that policy, and generate agonist during chemotherapy is very important, not only the woman who want to have a baby, but also the woman, even for the woman who is a little older premenopausal woman, but who want to preserve their ovarian function, right? And you also mentioned very important things. Our fertility plan should be discussed at the beginning of breast cancer treatment. So I think that is very important things. And how many patients choose embryo or oocyte preservation?
This is a very important question to try to have an idea on the numbers and on the volume that we have in terms of fertility preservation strategies. So what we have observed in our prospective national cohort study that is called PREFER, Pregnancy and Fertility. This is so out of the total number of young women under the age of 40, the majority of them are actually not interested in cryopreservation strategies. Only around 10-12% of them, so 1 out of 10 young patients is actually interested to have embryo and oocyte cryopreservation. This means that we actually do not need a fertility unit within the same institution, but what is really highly relevant in this field is to build a network between oncology centers and fertility units with a so-called hub and spoke model. So few fertility units, very experienced unit with very high success rate, where many oncology centers send interest patients to these fewer fertility units. This is very important to be built, this kind of network. And I want to go back to what I've just mentioned in my prior reply, saying that even though the number of patients interested in fertility preservation seems to be relatively small, this topic has to be discussed with all women, including patients that have already kids, so they have already their families. So we don't have to assume that fertility preservation is not important for a patient. We need to discuss that with all women. And according to guidelines, we also have to discuss this topic irrespective of stage and diagnosis. So also in patients with advanced stage, we have to discuss this topic. This does not mean that we have to proactively send patients with advanced breast cancer to fertility units, but that women should be informed about the side effects of treatment, including the potential negative effect on fertility and the option that we have for trying to avoid this risk. So I think that the two key messages are information first, and then building this network with our colleagues and fertility specialists and gynecologists.
Right. Do all hospitals have a fertility unit? Because in Korea, we also try to make consultation for that, but sometimes there are not many supportive systems. And I think for discussing fertility issues, we need a multidisciplinary team approach and enough time to discuss about that. So how about Italy?
Yeah, I think this is a crucial point, multidisciplinary management of young breast cancer patients in general, including about fertility and pregnancy-related issues. So what we, of course, if you have a fertility unit in each of, next to each oncology center or oncology unit is of course easier to make this network that I've just mentioned. What I want to stress one more time is that the success of fertility preservation strategies is strongly dependent by the expertise of the center. So the higher the volume of the center, the better the fertility outcomes and the fertility results of the procedure. So what we do here is actually to implement this kind of hub and spoke model, because not all oncology centers have just next door a fertility unit or a fertility center. So we have different oncology units sending patients to a more centralized and more experienced fertility center, because as I've mentioned, the percentage of patients that actually have access to fertility center is small if we consider the total number of young women. So this is our approach to try to implement among oncology centers the culture of discussing fertility preservation and making this oncofertility counseling, or at least the first step of the oncofertility counseling, so that oncologists know that patients interested in fertility preservation are then sent to fertility units, and they have all the contacts with fertility units around, like in the same region, to send this patient. But again, as you have mentioned, multidisciplinary management is key. And this is what we are trying to implement on a national level. And I'm very interested to know what about your multidisciplinary management in this setting and around breast cancer in young patients?
So in our hospital, we run young breast cancer clinic with a medical oncologist and surgical oncologist, including me, and also gynecologic doctor who is specialized for fertility counseling, and also radiologic doctors, and also with a psychologic doctor who need to consult their depression or anxiety. So we have started that clinic 10 years ago. So after that clinic, it's much easier to counsel fertility counseling for young women with breast cancer. And also if we introduce fertility a little later, patient hesitate to do or hesitate to choose that procedure because most patient does not want to delay their treatment. So I think more important thing is when we introduce or when we make breast cancer treatment plan, combining with that, make a fertility counseling and fertility plan is very important, because I don't want patient do not choose fertility procedure only because for delaying the treatment. So I have some plan to make the cohort study to implementing those multidisciplinary approach in Korea. And I want to change some topic. So fertility is very important for young women with breast cancer, but some patients worry about the pregnancy after breast cancer. Is it really oncologically safe for the young women with breast cancer? How do you think about that?
This is one of the important question and still safety concern that we have as medical oncologists. Breast cancer is a hormonally driven form of tumor, so thinking about pregnancy and the high hormone level for 9 months during pregnancy is something that is of concern. And we have recently done a survey among breast cancer physicians, and 30% of them, so 1 out of 3 responding physicians, was not sure that pregnancy after breast cancer is safe. However, we have now quite solid data, of course, mostly retrospective data, but several studies having the same conclusion, that after adequate treatment and follow-up, pregnancy after breast cancer is safe for the mother, meaning that pregnancy does not have any detrimental prognostic effect. We have done a few studies in this setting. We have done the only study so far that has shown the safety of pregnancy in the ER-positive patient population, so patients with hormone receptor-positive breast cancer, and the pregnancy following treatment completion have the same outcomes as young women without subsequent pregnancy. More recently, we have done a kind of similar exercise in the BRCA-mutated breast cancer cohort. Same conclusion, BRCA-mutated breast cancer patient following adequate treatment and the pregnancy following adequate treatment have the same survival outcomes as compared to BRCA-mutated breast cancer patient without subsequent pregnancy. So again, no detrimental prognostic effect of pregnancy. And in these days at the San Antonio Breast Cancer Symposium, we are actually presenting, and you know very well this study because you are a co-author of it. We are presenting a large meta-analysis to try to kind of give a solid, a final and solid answer on this question. So we have put together the results from 39 studies that have assessed pregnancy after breast cancer. We investigated chances of post-treatment pregnancy among breast cancer patients as compared to the general population. We have assessed pregnancy complication, pregnancy outcomes in breast cancer survivor as compared to the general population. And then we have also assessed the maternal safety, so disease-free survival and overall survival in breast cancer patient with a pregnancy following treatment completion as compared to those without a subsequent pregnancy. And the main messages from this meta-analysis, putting together all these studies and very big numbers: breast cancer patients remain among cancer survivors those with the lowest chances of future pregnancy, together with cervical cancer survivors. One of the potential reasons is the safety concern that we have as physicians. However, I think we provided solid data to kind of dispel this concern. No negative effect for the mother, so actually better disease-free survival and overall survival for patients with a pregnancy following breast cancer as compared to those without a subsequent pregnancy. So no negative prognostic effect of pregnancy. And also on the baby side, the safety on the baby side, we observed that there is no significant increase of malformation, and there is no significant increase of the majority of pregnancy complications as compared to the general population. There are some complications that are higher in breast cancer survivors, like preterm birth, cesarean section, small for gestational age, and low birth weight. And this is the reason why we need to monitor these pregnancies more closely than what we normally do in healthy women from the general population. But in general, the main message is that pregnancy after breast cancer, again, following adequate treatment and follow-up, should be considered safe on both the mother side as well as the baby side.
Mm-hmm. I think that this is a very important study. I really appreciate and congratulations for your amazing study. It will be great message for young women who want to have for young women with breast cancer who want to have a baby or already pregnant. And I'm looking forward to seeing your study in GBCC next year. And so while pregnancy, the chemotherapy and surgery probably safe. Can you explain your policy for the woman who is pregnant but who have diagnosed breast cancer?
Breast cancer during pregnancy is another very important and special issue for young women with breast cancer. Fortunately, this is a rare situation, but for those of us that are managing every day in their clinic young breast cancer patients, this is something that can happen. So as physicians, we need to be prepared to treat and to manage properly this patient. First important message is, again, going back to the multidisciplinary management. This is highly relevant for breast cancer in general, but it's particularly relevant for this specific setting, so breast cancer during pregnancy. In these regards, in terms of anti-cancer treatment we can give, surgery is feasible and safe throughout the pregnancy, so in the first, second, and third trimester. Systemic treatment, the only one that we can give to this patient is chemotherapy, but only in the second and third trimester. Chemotherapy is not possible, is not safe in the first trimester because it's associated with a very high risk of congenital malformation, but it can be safely given during the second and third trimester. I mean, anthracycline and taxane-based chemo, so the one that we normally use for breast cancer. All the other treatments, anti-HER2 therapies, endocrine therapy, as well as radiotherapy should be postponed after delivery. This means that treating patient with breast cancer during pregnancy is feasible, but the trimester at the time of diagnosis is key to decide which is the optimal care and the optimal path for this patient. So if the woman is diagnosed in the first trimester, you can give surgery and then she can wait the second trimester to start chemotherapy. However, we have some situation in which we cannot operate the patient and we need to start urgently systemic treatment. In these cases, and this is the only situation in which we can discuss pregnancy termination, because there we cannot wait the second trimester to treat the patient. In the other situation, so or diagnosis during the first trimester in which surgery is possible, or diagnosis in the second and third trimester, we should not discuss pregnancy termination because we can give treatment, again, surgery and chemotherapy in the second and third trimester. For chemotherapy, the majority of the safety data we have are with anthracycline-based chemotherapy, but we also have safety data with taxane, so taxane can also be given during pregnancy. What is very important in this setting is to try to bring the pregnancy at term, meaning to week 37, because it has been clearly shown by the group of Amanta and this INSIP registry, this core study ongoing in Europe, that prematurity is associated with the potential detrimental cognitive development of the babies following delivery. And on the contrary, chemotherapy per se does not seem to be detrimental in these regards. So the main message is that it is better to give chemotherapy during the second and third trimester to bring the pregnancy at term than the other way around to induce the birth, the delivery, maybe in the early third trimester to give the treatment afterwards. So this is very important. We should give treatment to bring pregnancy at term. And then, as I've mentioned, for pregnancy after breast cancer, also for pregnancy during breast cancer treatment, we need to monitor more closely this pregnancy for potential pregnancy complication, again, in terms of preterm birth and potential delivery complication. So we need to pay more attention also on the follow-up of these pregnancies.
So can you conclude what is a more important message for young women with breast cancer in the treatment, but also the research field?
I think it's very important to build a multidisciplinary care for breast cancer in young patients. This is important for breast cancer in general, but particularly for young women, as we have just mentioned. This is because there are several important issues, from kind of difficult treatment choices to genetic counseling to fertility in pregnancy, and maybe the management and the care of patient diagnosed during pregnancy. So we need the help of different specialists to properly manage this patient. And I think, as a closing remark, I think it's important to stress that we have guidelines specifically focused on the care of breast cancer in young patients. These are the so-called ESMO BCY guidelines, and the last one has just been published in Annals of Oncology in 2020, so a few months ago. There are here in these guidelines all the most important recommendations on what to do and how to properly take care of young breast cancer patients. So I think it's important to stick to the guidelines for everything in medicine, but particularly important in this specific setting.
Thank you so much, Dr. Matteo. I really appreciate all your precious time and all your research for young women with breast cancer. I'm looking forward to seeing you in next year in GBCC.
Thank you very much. I'm really looking forward to see you again and be back to Seoul soon.
Okay.
Thanks a lot.
Bye.
Bye, ciao.